Good morning, everyone. Thank you for joining us for today's webinar on the impacts of antimicrobial resistance on cancer care. My name is Sujan Reddy, and I'm an infectious disease physician and the director of the Office of Prevention Research and Evaluation in the Division of Healthcare Quality Promotion at the US CDC. Welcome to the 8th installment of CDC's AMR Exchange Series. The purpose of this webinar and this series is to share cutting-edge impacts in the research in the field of antimicrobial resistance. We want to drive the field, share what we're learning and what's been working. We also want to collaborate across One Health, which involving sectors of the healthcare community, the community, and the environment. We appreciate everyone answering today's poll, and it looks like there's a fair amount of people today who are aware of the connections between antimicrobial resistance and cancer care, and many of you work on both AMR and in the cancer community. And I imagine we have a few patients and survivors as well. So thank you all for joining today. I want to introduce you to our 6 panelists today. First, we have Josh Glasser, who is Assistant Director for Combating Antimicrobial Resistance and Integrated Health Innovation at the White House Office of Science and Technology Policy. Next, we have Lillian Sung, who is Professor, Senior Scientist, and Chief Clinical Data Scientist at the Hospital for Sick Children. We also have Shalini Jayashekhar Zern, who is Senior Advocacy Manager with the Union for International Cancer Control. We also have Diane Flahart, who is the Director and Global Program Leader for Antimicrobial Resistance at BD. Next, we have Jen Wargo, who is a Professor of Surgical Oncology and Genomic Medicine at the University of Texas MD Anderson Cancer Center. And we also have Minnie Cambodge, who is an infectious disease physician and Chief Medical Epidemiologist at Memorial Sloan Kettering Cancer Center. Thank you all for joining today. Josh, I wanted to start with you. Do you mind introducing yourself to the audience?
Sure, I would be happy to, Dr. Reddy, and thank you so much for the kind invitation to address this group. My name is Josh Glasser. I'm Assistant Director for Combating Antimicrobial Resistance and Integrated Health Innovation at the White House Office of Science and Technology Policy, OSTP. OSTP works with partners inside and outside of government to strengthen American science and technology while promoting equity, inclusion, and integrity via S&T policy. We're also home to the Biden Cancer Moonshot. It's fitting that we have such a diverse audience from across the country and around the world on the webinar today, as this is truly an all hands on deck problem. The Biden Cancer Moonshot exists because cancer touches every American in some way. That's why accelerating progress against cancer is a central pillar of President Biden's unity agenda, issues that we can all get behind to deliver for the American people. And when reigniting the Biden Cancer Moonshot in 2022, the President and First Lady set 2 ambitious yet achievable goals. One was to reduce the death rate from cancer by at least 50% over 25 years, which would prevent 4 million deaths by the year 2047. And second, to improve the experience of people and families facing cancer. To achieve both of these goals, we must equitably increase access to tools and approaches that we already have and those that we are developing, including for antimicrobial resistance, AMR. We need all of you in order to end cancer as we know it, combat antimicrobial resistance, and address the many linkages between the two. Now, I say many linkages, but I recognize that in some quarters, there is limited recognition of how these issues are linked at all. I admit that I had this limit to my understanding for many years. Perhaps this is to be expected. While both are public health problems, AMR arose from infectious disease quarters of public health and has been the focus of health security actors, whereas cancer arose from non-communicable diseases side of the house that has been the focus of healthcare delivery actors. But the linkages are clear. People living with cancer are more susceptible to a wide array of infections due to immunosuppression occurring with cancer treatment. Indeed, as I understand, up to 1 in 5 people living with cancer experience hospitalization due to an infection during their treatment. Let me say that again, 1 in 5. Of course, many of these will be AR infections. So initiatives that preserve antibiotic efficacy and bring new treatments online have major and direct benefits for people living with cancer. Thanks to many dedicated scientists and advocates, including people living with cancer and their families and their loved ones, these linkages are increasingly understood and acted upon, including by many folks who are speaking on the agenda today. In addition to our leadership on cancer, the United States has long been a global leader on antimicrobial resistance. And indeed, President Biden's FY25 budget includes $9 billion to incentivize development of additional tools to fight AMR. We are also actively preparing for the UN General Assembly high-level meeting on AMR, which will take place in September in New York, which is another chance to spotlight these issues and linkages. Let me close with a note of urgency of this particular moment. Every year around the world, we lose 5 million people to AMR, including 28,000 Americans, and 10 million to cancer, including 600,000 Americans. Combined, AMR and cancer are placing immense pressure on our healthcare systems, on our public health institutions, and on our communities. Tackling them individually is a tall task. Tackling them jointly, whenever it is feasible to do so, is vital, especially in the context of health systems that are already severely strained by a years-long pandemic. These are not small goals, and it is not a modest mission. The mission comes directly from the President of the United States, who has called on all of us to step up and solve these pressing challenges. We need everyone in the boat, all oars in the water. So I applaud the organizers of today's webinar, and I applaud all of you for speaking, listening, and joining the conversation. It's a unique topic and a timely opportunity to hear from experts working in healthcare, academia, and government about preventing infections, preserving effectiveness of antibiotics, and applying unique scientific approaches, including the microbiome. I look forward to the discussion. My notepad is ready and my pen is poised. Thank you so much.
Thanks so much, Josh. That was a great introduction to the issue, and obviously the large burden that people with cancer have with infections and antimicrobial resistance is really important to highlight. Also appreciate that it's going to take a multi-pronged approach, right, to address both cancer and AMR. So appreciate your leadership in this space. I want to next turn to Lillian. Lillian, do you mind just introducing yourself to the audience again?
Good morning, everybody. I'd like to start by thanking you for inviting me to talk in this really important event. I'm Lillian Sung. I'm a pediatric oncologist. I also have training in pediatric infectious diseases, and I'm a clinician scientist, meaning that I conduct research in this really important area and try to disseminate information that improves the outcomes for children with cancer.
Great. Thanks for joining us, Lillian. So your work at the Hospital for Sick Children in Toronto is, as you mentioned, about clinical research and optimizing care for children with cancer. We want to hear from you from your clinical perspective and your personal experience with caring for people with cancer and how that's how has antibiotic resistance affected their lives and your work with them?
Thanks so much for the question. So maybe I'll just start by saying that my work focuses on supportive care. So supportive care refers to all the approaches we use to support patients, children, their families, these patients with cancer. And this includes, but is not limited to, preventing and treating infections, addressing symptoms, and maximizing their quality of life. So to provide the best supportive care for children with cancer, it is important to practice evidence-based medicine. So that means that for many conditions, researchers have conducted studies such as randomized controlled trials to determine the best course of action for a given condition. The great news for all of us is that the pace of research is fast, it's exponential. There are new publications and new studies coming out every day. So that's great. However, this is becoming a problem for busy clinicians who cannot keep up with the literature and their busy practice. Further, we know that in general, only about 30% of patients receive care that is recommended, and about a similar number receive care that is contraindicated. Thus, one of our goals is to create clinical practice guidelines, which are documents that identify all the literature conducted on a specific topic synthesizes that literature, and makes recommendations that consider the benefits and downsides of different treatment options. In the setting of AMR, we have created guidelines that focus on the initial and ongoing antibacterial and antifungal therapy for children with cancer. And our goal is to keep these patients safe while reducing unnecessary antibiotic therapy, which contributes to AMR. So it is important that guidelines are created properly, or in other words, that they're trustworthy, since they're meant to directly influence patient care. So these are long documents that are subsequently published in peer-reviewed literature. However, you can imagine that this structure makes it really hard to use these documents when caring for patients. So no one has time to read a 5-page or 10-page document in the middle of a busy clinic. So to make these guidelines usable by clinicians, we've taken an additional step, which is to focus on creating care pathways. For example, we have care pathways focused on infection, prevention, and treatment for pediatric cancer and transplant patients. These care pathways reflect the guidelines, so the recommendations in the guidelines, but they also consider the values, preferences, and resources, as well as specific antibiotic resistance patterns at individual institutions. So our research has focused on the development of these care pathways and determining ways to adapt and implement them so that they can improve outcomes for individual children. We've also focused on harmonizing these care pathways across institutions, particularly when patients from many institutions are cared for by other institutions. We don't want to create confusion by having different practice patterns. You asked a question about how AMR has affected my patients. So first, as AMR increases, it means we need to use more powerful and sometimes more numerous antibiotics. So for example, there is a strong recommendation in the guidelines to use only one antibiotic for patients who develop fever when patients with cancer have low counts or that they're neutropenic. However, if a center has lots of AMR, sometimes you have to use 2 or even 3 antibiotics routinely for these patients. Giving extra antibiotics routinely increases the likelihood that you will further worsen AMR. In other words, this becomes a vicious cycle that once you have AMR, you need to use more antibiotics, which contributes to more AMR. Second, for patients who are infected with AMR or colonized with AMR, it not only increases the risk of bad outcomes, including outcomes as bad as death, but it also results in isolation, meaning that these children, when they're admitted to hospital, need to stay in their rooms. So many of you in this audience will be parents. I would like you to imagine being a parent of a child who has to be in hospital for many, many days. And imagine what it would be like for that child who is unable to leave their room. And imagine the impact on their quality of life for that child and their family. And indeed, I can assure you it does influence their quality of life. In terms of what I've seen many patients die of AMR. It is the worst thing a parent can imagine, and one of the worst things that we as healthcare professionals need to face. This outcome, including many other outcomes of AMR, really stresses the urgency of addressing AMR. And to speak to Josh's point, really is a call to all of us to invest in AMR prevention and think about ways we can mitigate this terrible condition. Thank you very much.
Thanks, Lillian. That was really helpful. I mean, I think what we'll hear today, and as we already started hearing from Josh, is we'll be talking about policy initiatives, lots of partnerships, talk about research. At the end of the day, we want to affect individuals' lives, right? And you're at that point, you're at that tip, right, of translating all this evidence and all this policy to improve individuals' lives. And it's really important to hear that perspective as we think through this next hour together, keeping in mind actual patients' lives and how we can improve, obviously, the longevity of their life, but even their quality of life, which you touched on nicely there. So really appreciate those comments there. I want to turn next to our panelist. Shalini, I'm going to turn to you, and do you mind just reintroducing yourself to the group?
Yes, of course, Sujan. So good morning and good afternoon, everyone. I'm Shalini Jaishekhar-Zyud with the Union for International Cancer Control, or UICC, and I'm a senior advocacy manager with UICC, and I'm the focal point for all treatment issues. And I'm really glad to be a part of this panel, so thank you for having me.
Thanks for being here. So the UICC, the Union for International Cancer Control, is one of the longest standing organizations that addresses cancer control on a global level. Could you tell us a little bit more about the work that UICC does and how UICC is prioritizing this intersection of antimicrobial resistance and cancer research?
Yes, thanks for the question, Sujan. So first, a bit about UICC. We are the oldest and largest cancer-fighting organization globally, established in 1933. And we're a membership organization, so we have over 1,100 members across 172 countries. And we unite and support the cancer community to reduce the global cancer burden, to promote greater equity, and to ensure that cancer control continues to be in the World Health and Development Agenda. And that's actually our mission statement. And this is what makes UICC unique. We are the only global cancer organization covering all cancers across the continuum of care, so prevention, access to treatment, etc. And we help drive global impact by bringing cancer to the attention of global leaders to help ensure that targeted commitments are made to reduce the burden. For example, through the World Cancer Resolution or the Global Strategy to Eliminate Cervical Cancer that UICC was very actively involved in. And we also help to ensure that all countries develop and implement a National Cancer Control Plan, or NCCP, and that national health investments in cancer control increase over time. And UICC pays special attention to our members and provides a range of learning opportunities that include online learning, mentoring for patient groups, and of course, access to events like the World Cancer Congress. And some of the priority areas we've been focusing on for the past few years include women's cancers, access to medicines, tobacco control, and of course, antimicrobial resistance now. And now I'll talk a bit more about how UICC is making AMR a priority. Josh mentioned this twice, and I'll say it for the third time. As many as 1 in 5 cancer patients undergoing treatment are hospitalized due to infections. And antimicrobials like antibiotics and antifungals are the main line of defense. And furthermore, infections are the second leading cause of death for people living with cancer. So access to appropriate treatments for infections is just as important as access to essential cancer medicines to ensure appropriate cancer treatment and care. So UICC made addressing this issue a priority, and we started our program of work in 2020. And the first thing we did was to set up a task force of experts to guide us. And the experts are from the infectious diseases community and the cancer community. And this task force showcases current evidence, identifies research gaps, and helps us in engaging the cancer community to bring about policy change on addressing the threat of AMR. So UICC leverages its global networks and platforms to raise awareness and share knowledge on the importance of addressing AMR in cancer care. So this includes incorporating AMR-related topics into UICC's platforms like the World Cancer Congress, World Cancer Leaders Summit, campaigns during World Antimicrobial Awareness Week in November every year, and of course, advocacy efforts with our members. And UICC also helps with collaborations between cancer researchers and infectious diseases specialists to conduct research on the intersection of AMR and cancer. And you'll actually hear about one of these studies later on during the webinar. And with the help of our expert members, we aim to develop resources to help cancer organizations and healthcare providers integrate AMR considerations into cancer care. And one example is the AMR control supplement that focused on how AMR impacts cancer care, and what we can do to address this. This was written by our over 50 experts, and it's an excellent reference for the cancer community and a key resource for advocacy efforts, all aimed at policymakers to mobilize policy change. So we're really pushing the message that if AMR is not addressed, all the progress made in cancer treatment and care will be undermined.
Thanks, Shalini. I agree. That resource that you just alluded to is an excellent resource for others to check out on your website. So you have extensive experience working to understand cancer control and access to appropriate treatments for cancer. How can public health organizations leverage the cancer control resources and tools to address these global inequities in AMR?
Thank you. Another excellent question. So global health inequities in AMR is a huge issue that needs urgent attention. In fact, low and middle income countries experience the highest rates of infection, the highest rates of AMR, and suffer from significant gaps in access to adequate treatment. The 2019 Graham report, which provides the first comprehensive estimate of AMR burden in 204 countries, identified the highest burden levels of AMR in low resource settings. And also another recent study showed that 50% of medicines listed on the WHO model list of essential medicines are below, in fact, less than 50%, are available in low and middle income countries. And furthermore, WHO also forecasts that the majority of cancer deaths will occur in LMICs in the next 10 years. So as I already mentioned, infections are the second leading cause of death in cancer patients. So access to these antimicrobials is vital for cancer treatment and care. Just vital. This message has to be put across that you don't just need essential medicines, you need antimicrobials as well. So ensuring this treatment globally, both for cancer and antimicrobial medicines, I'll keep saying that, requires a multi-sectoral approach that involves collaborations among public health organizations like cancer societies, the WHO, working with governments, healthcare providers, researchers, civil society, the private sector, and also engagement at the community level. And here are some ways to address this global health inequity. The first one is National Cancer Control Plans, or NCCPs, are an important first step in effectively addressing the cancer burden and to prioritize and coordinate programs. So here, cancer organizations can work with governments and other stakeholders to push to include AMR into national cancer control plans as a first step in ensuring access to treatment and diagnostics. And the second one is data collection and surveillance. Data is so important here, and it is also currently lacking. So appropriate AMR surveillance systems help to monitor the impact, lead to evidence-based interventions, help with addressing AMR, and guide resource allocation. Cancer organizations can support and push for the development of robust data collection mechanisms and lab infrastructure, and collaborate with infectious diseases groups to guide data collection at both the facility and national levels by integrating microbiology data with cancer registry data. And the third one is ensuring access to appropriate treatment. So the lack of access to treatment, both existing and novel therapies, is a driver of AMR, especially in low and middle income countries. So some of these reasons include challenges with supply chain and regulatory capacity, pricing challenges, limited availability of source materials, and a fragile pipeline for the R&D of new antimicrobials. In fact, few candidates are in the clinical pipeline right now, and fewer still with novel mechanisms of action. So fragmented access to diagnostics and selecting suboptimal therapies for infections can lead to negative outcomes and actually hinder cancer treatment. So here the cancer community can join forces with the infectious diseases community and advocate for sustainable access to quality assured essential medicines, especially those listed on the WHO model list of essential medicines. And of course, not forgetting the importance of diagnostics, accompanying diagnostics. And also to push for new treatments, ensuring that access pathways are in place globally for these novel treatments. That's also very important. And then using mechanisms like voluntary license agreements or tiered pricing, etc. So this can all play a crucial role in ensuring access to treatment and addressing AMR, ultimately improving health outcomes for people living with cancer across regions.
Thanks. That was really helpful. Yeah, I appreciate that multi-pronged, working with the national cancer control programs, thinking about how to improve AR surveillance, and then, that advancements in treatment and access to treatment, and not just cancer treatment, but antibiotic treatment, right? The antibiotics and the innovation pipeline that is sorely missing for antibiotics. So appreciate that response. My last question to you has to do with partnerships. You work very well with engaging patients and caregivers and healthcare providers, and it's critically important as we think about the challenge of AMR. Do you have suggestions of how we can effectively engage the cancer advocacy and research community to advance these shared goals between AR and cancer?
Yes, thanks, Sujan. So unlike other diseases, AMR doesn't have a single identifiable face. It's a complex and widespread issue affecting all medical treatments across therapeutic areas. And this silent pandemic requires immediate action and dedicated champions who can effectively represent the cause of AMR. And the cancer community, which is disproportionately affected by AMR, is ideally placed for this role. But for the moment, all the concerned groups are actually continuing to work in silos. So I'll talk about two ways where the cancer and infectious diseases communities can join forces in addressing AMR in order to have better cancer care outcomes. So the first one is education and awareness. Currently, there's a lack of awareness on the impact of AMR on cancer care and treatment. Cancer organizations have to come together with AMR groups to raise knowledge and awareness on what AMR is, emphasizing the interconnectedness of the issue, the AMR and cancer, and how it's a serious threat to global health, its negative impact on cancer care outcomes, and ways in which we can address this, including through campaigns to raise awareness on the issue among the public, people living with cancer, patient groups, the oncology health workforce, and policymakers. Just to give one example, minimizing the use of antibiotics when they are not needed, such as when treating viral infections, should be highlighted in a big way. And the second one is clinical practice guidelines. So you have the WHO AMR handbook, the IDSA guidelines, etc. But these need to be adapted for different settings. And here the cancer community can work with professional organizations and guideline committees to incorporate recommendations for ensuring antimicrobial stewardship into cancer treatment guidelines, and to also ensure that healthcare providers have access to evidence-based guidance on antimicrobial prescribing and infection management in cancer patients. Thank you.
Great, thanks so much. Yeah, we'll definitely be touching upon that antibiotic stewardship element as we go along, especially as we talk through disruptions to the microbiome and other issues. So thank you, Shalini. That was really insightful to hear your global perspective, hearing the inequities that are occurring related to AMR globally and different approaches of how we can approach this. I want to move next to Diane Flayhart at BD. Diane, do you mind reintroducing yourself to the group?
Sure. Good morning, good afternoon, everyone. Diane Flayhart from BD, Becton Dickinson. BD is a global medical technology company. We seek to improve medical discovery, diagnostics, and delivery of care across the globe. We work in about 190 countries and have about 70,000 associates on our team. So delighted to be here, and thank you for having me.
Thanks for being here, Diane. So your work at BD focuses on AMR initiatives that raise global awareness and improve infection prevention and control and antibiotic stewardship, which we were just kind of alluding to. And you work across, various sectors to drive advocacy, policy, and innovation. From your perspective, what kinds of programs are needed to better address antimicrobial resistance and to protect cancer patients? And what data is needed to address this problem?
Sure. So, great question. Thanks, Sujan. A lot of efforts needed, to really combat AMR here in the U.S. as well as globally. But maybe a focus on a few of those. The first one is awareness of the issue. Raising awareness is crucial because, as we're discussing, AMR threatens everyone, and most especially those patients that are vulnerable, like our cancer patients. And while great strides have been made with cancer care and new therapies, our development of new antibiotics is lagging behind. And what's more scary is the bacteria that are causing those infections are actually moving faster. So we have the microorganisms that are really being smart and savvy and evading the current therapies, and we don't have a good lens on new ones coming to the market. So we really need to raise awareness, not just with those of us who are working in the space of infectious diseases and cancer care, but those outside the space as well, so they understand how to use and how to appreciate the antibiotics we have today. So an example of what we do there is we partner with CIDRAP on a podcast series called Superbugs in You. And this podcast series is targeted to the general population, so they understand all the great work that's happening and what actions we want them to consider based on what they're hearing from these experts. Last season, we had an episode specifically on AMR and its impact on cancer patients. So we are trying to raise awareness of how these issues are linked. As Shalini was mentioning, it's so important to link these conversations together. And from a measurement perspective, we post our podcasts on the Antimicrobial Resistance Fighter Coalition website. That coalition seeks to raise awareness of the issue via many different educational tools. But while we measure the sites, site visits, when people come to the website, how many times the podcasts are downloaded, what we really need from a data perspective is we need to start to measure how we understand the scope of the issue of AMR and amongst the general public. So we need to start to think about how do we develop better ways to measure awareness with everyone around the globe of this important issue, so we can change it from a silent pandemic to a known pandemic. Moving to the second area is probably diagnostic and antibiotic stewardship is another area we focus on. The use of diagnostic tests are critical, and they vary greatly around the world. So it's we need to be using a diagnostic to understand what is causing the infection and what antibiotic we should be using that's going to be most effective. However, there's opportunities to build capacity. For instance, in Africa, there's a study that indicates that only 1.3 of all labs in Africa are currently completing bacteriology testing. So those labs that can generate an identification and susceptibility result are lacking, and there's patients receiving cancer care in those communities, and they don't have access to the microbiology side. So how do we build capacity and develop lab strengthening programs to improve access to all that data? And probably another part of that is antibiograms. I think Shalini kind of talked about data and antibiograms. Antibiograms are critical to understand those local resistant rates. They're critical within a local hospital setting, but also maybe within and I'll touch on this in the next section, a specific population. And how do we make those antibiograms granular enough to really understand the impact and the burden of those drug-resistant infections? Just last week, the International Society of Antimicrobial Chemotherapy just released a new training tool on antibiograms. So for anyone listening who wants to figure out how do we up our antibiogram, that is a great tool that's currently available. And it's one of those massive online free courses, so you can just jump in and learn. And then finally, moving to surveillance, maybe it's one comment there where we know that, once again, you need to be generating the doing the data from the diagnostics. That's going to improve the clinical care, but it's also going to build that knowledge of where the organisms are and how do we track those infections. We've learned from COVID that these bugs move around the world quickly. Bacteria are the same. So whether it's a virus or a resistant salmonella typhi or a resistant gonorrhea, they're going to move just as quickly as a virus does. So surveillance is critical to allow us to track where these organisms are and then better protect our patients, to include our cancer patients.
Thanks, Diane. There's always a lot to respond to in these comments that you all are giving. I just want to highlight that diagnostic part. It clearly plays a big role globally. And then also, in the US as well, of trying to improve new diagnostics for infectious diseases, but then even our stewardship of these diagnostics to improve antibiotic use. So really appreciate those comments. And for those in the audience who are not familiar with antibiograms, it's basically, you take a hospital facility or an area and you look at all of one particular pathogen, let's say E. coli, and it's just to say how much of that E. coli in that hospital is resistant to antibiotics. And it's a way of measuring antibiotic resistance to some regard and help antibiotic use. Kind of alluding to that, Diane, BD has started the Cancer and AMR Consortium, which is an international effort with the goal of building the evidence base of quantifying the dangerous synergies between AMR and cancer. Can you share some highlights of the data that you've analyzed thus far and possible implications of what you're finding?
Sure. So a little bit of background on the Cancer and AMR Consortium. So we have the Graham report that has very powerful data to understand the burden of AMR around the world. However, it doesn't show the impact of specific populations. In 2021, there's a publication in Cancer that called out the lack of data in the etiology of infections, specifically in oncology patients. And this was a concern. There's a need that data needed to be better understood and generated. And as we discussed, we know, if it's 1 in 5 patients going to get treatment, how often are the infections that we're treating resistant? And are they at the same level of resistance, meaning the burden, is it at the same as we see in our entire hospital setting, or is it different for the cancer patient? So really that was the question that we were all asking. And so working with UICC and members of their AMR task force, of which a few are on the panel today, the AMR Action Fund, infectious disease and microbiology specialists representing American Society of Microbiology, and many others, we started this consortium to focus on the need to collect that data. So the initial work of the project is we have developed a study design and a methodology that allows us to compare cancer to non-cancer populations. This data set has been used previously to understand the burden of AMR. And what we do is we layered upon that, how do we separate and understand different populations within that large data set. So doing this multi-center real-world analysis, we were able to compare the incidence and prevalence of these isolates and their associated resistance in both hospitalized patients with and without cancer. So where we are with the data is the inpatient analysis has been completed, and there's about 4.6 million admissions in the analysis, of which 6% of those admissions are patients with cancer. We define patients with cancer either based on the medication they're receiving or the location they are in the hospital. And then we're able to compare positive cultures from those patients as compared to the rest of the patients in the hospital to see what bacteria are isolated and what the resistance profiles look like. The analysis includes both gram-negative and gram-positive pathogens, and it is looking across several culture sources. So we're looking at all sources like blood, urine, respiratory, skin and wound. So we're really trying to look broadly across all the areas where potentially a patient could have an infection. And across all those sources, across those 4.5 million admissions, what we saw was there's about a 1.5 to 2-fold increase in drug-resistant infections in cancer patients compared to non-cancer patients. So while we know cancer patients get more infections than the non-cancer patients, there's actually a 1.5 to 2-fold increase above that of drug resistance. So this data is helping inform us to better understand the impact of AMR in the cancer community. For bloodstream infections, when we look specifically at that, which we know have a associated higher mortality, the incidence of resistance there was 2-fold higher and ranged anywhere between 1.5 to 3.95-fold higher. So when we think about the most critical infection, where we want to make sure we have the right antibiotic or antibiotics as quickly as possible to treat that patient, the burden of AMR is really high there as compared to the non-cancer group. So the impact is we need to enhance our infection prevention practices, our diagnostic and antibiotic stewardship efforts all need to improve, to include, as I mentioned, as antibiograms, the potentially cancer-specific, cancer location-specific antibiograms may be of use, and then efforts to improve the monitoring of AMR in persons with cancer in the United States is critical to inform the development of more effective infection prevention and control practices. We also hope that this data will inform policy and action. So as we think about things in the United States and the Pasteur Act, which is an act looking to help the development of new novel antibiotics, as well as global policies to help drive better utilization of diagnostics across the globe, we really want to hope that this data helps people see what the scope of the problem and understand while we're doing a great job on the cancer therapy side, we also need to focus on the infectious disease side. This data has been presented in poster form, and we'll have a manuscript shortly. It's in development, and we'll also have our outpatient data done in the next couple months here, and we'll be glad to share that in the future.
Great, thanks, Diane. I think it'll be great to see that data. And just as we were talking about AMR surveillance, right? We want to be able to know the burden and what's happening with AMR in general, but having it by subgroups, in particular, like by cancer patients, is really helpful for awareness, as you're kind of mentioning, but then harkening back to what Lillian was talking about, for clinical guidance, right? If understanding how AMR affects this particular population can help clinical guidelines, create guidelines that are more targeted with their appropriate antibiotics, knowing what resistance is in those communities in particular. So that data is going to be really helpful. Appreciate you doing that. My last question to you is that, it's clear that we need more. There's an ongoing need for existing, more innovation to address antibiotic resistance and expand healthcare access and, in general, strengthen global health systems to fight cancer. Are there any healthcare products in the pipeline that could be important for reducing infections, whether it's antimicrobial resistant or not, for cancer patients?
Sure. So briefly, I'll just highlight two examples. One is expanding healthcare access to current diagnostics and current antimicrobials. As I mentioned, some parts of the world lack access to the current diagnostics that are available today. And as example, we are working with Fleming Fund to provide diagnostic equipment and informatics solutions to help in the diagnosis of infectious diseases in 16 countries. And we supported and equipped over 70 labs in those countries with instrumentation to detect bloodstream infections, as well as in complete ID and susceptibility testing. This expansive effort really will help improve capacity and allow more understanding of that local data of how much resistance is present in those hospital systems. As next steps, we're working with those laboratories to continue to build capacity with training programs like the AMR scorecard, which is a tool which helps labs develop quality systems around their microbiology testing, and the Super Labs Against Superbugs program, which is a health system strengthening program that is addressing opportunities for improvement both inside and outside the laboratory. So of course, what we do in the microbiology lab is impacted by everyone outside the lab as well, right? So we need that continual ecosystem working together, collecting the best samples to send to the lab, getting those results sent back to the clinician effectively, and all the good things are happening in micro. And my second example would be innovation is critical. Faster is better. We know that. So we partner with a company that is developing and is selling a rapid diagnostic, which from a positive blood culture, instead of waiting a day or two for a result, you can get results in hours, both identification and susceptibility. So that's really important, especially since I highlighted that in our data, cancer patients have a significantly higher burden of drug-resistant infections. Knowing what that bug is quickly as possible is really important. So that sort of innovation, I think, is crucial in our efforts to combat AMR, especially in the cancer population.
Thanks so much, Diane. That was really helpful to hear all the work that BD is doing and all the partnerships that you're making and the data that you're generating. Really appreciate that. Next, I want to turn to Jen Wargo. Jen, do you want to reintroduce yourself to the group?
Yeah, sure. My name's Jen Margo. I'm a professor of surgical oncology and genomic medicine at MD Anderson Cancer Center. Wear a couple of hats. See patients, do surgery, run an active research lab, and I also run our program for innovative microbiome and translational research, or Prime CR. So happy to be here.
That is a few hats there. And nice. Thank you for being here. So you've done extensive research on the role of the microbiome in cancer outcomes. And for those that are not familiar with that term, microbiome is just the naturally occurring organisms that live in and on our bodies. You've been studying the microbiome in relation to cancer target therapy, immunotherapy, and other just cancer therapies. Could you share more on the importance of this research and the impact of the microbiome on cancer-related outcomes?
Yeah, definitely. And, I think really to put it in perspective, if you think about an individual, there's around 20,000 human genes, which represents only 1% of the total genomic content, but there's between 2 and 20 million microbial genes, which is 99% of the total genomic content. And, importantly, these are inherently modifiable. So you can imagine that these microbes and their genes actually have profound impact on our physiology and on disease. And so we first actually studied the role of these microbes and tumors of patients with cancer. Before I came to MD Anderson, I was at Harvard, and we actually, through serendipitous turn of events, we actually identified that there were bacteria within tumors of patients with pancreatic cancer that could actually break down chemotherapy into its inactive form. And that's really how we started to study the microbiome. And so, after I joined MD Anderson, my group next studied the role of microbes in the gut in promoting immune responses and responses to cancer immunotherapy. And basically what we did is we had seen data presented in preclinical models that these gut microbes may shape immunotherapy responses. So we studied it in patients who had cancer and were going on to treatment with immunotherapy. And what we found is that if patients had a more diverse gut microbiome, which is generally associated with better overall gut health, that they had better outcomes to treatment. And if they had different bugs in their gut, like a higher abundance of these response-associated taxa, like Ruminococcacea and other bugs, they actually had much better outcomes. And importantly, they also, the absence of deleterious taxa was also really important. So if you didn't have unfavorable bugs in your gut. And these results really had a couple of important implications. One is that, could we actually use the gut microbiome as a biomarker of response? And these are fecal samples, right? Could we have a poop test that, will actually tell someone how good is your microbiome and, will you respond to this cancer treatment or not? And secondly, we may actually be able to target the microbiome therapeutically to improve outcomes in cancer care. And so along with others, all of these studies really inspired the scientific community to pay closer attention to the microbiome in cancer. And now many, many studies have been published demonstrating the importance of the gut and other microbiomes in treating cancer and in overall health. And with regard to antibiotics, this is really important, right? And studies have actually shown that if patients receive treatment with broad spectrum antibiotics before they go on to treatment with immunotherapy, like immune checkpoint blockade or even CAR T therapy, that they don't respond to the treatment, right? And they actually have worse outcomes, worse response rates, worse survival, and higher rates of toxicity. I've actually had patients come into my office and, they've been put on a course of antibiotics for an upper respiratory infection. And they ask me, is this why I didn't respond to the cancer treatment? And it's heart-wrenching, right? So I think this is really a timely topic. Now we later actually built on this work and showed the importance of diet as well in shaping the function of these gut microbes in response to cancer treatment. And we actually showed that if patients consume sufficient dietary fiber intake of at least 20 grams a day, that they're much more likely to respond to treatment with immunotherapy. We actually are treating patients now with dietary intervention studies and really seeing some really interesting results. And we also showed that the use of commercially available probiotics that you could buy off the shelf at a pharmacy was actually associated with worse outcomes. So I think there's a lot to learn here and to unpack, and a lot of opportunities as well. Now, we and others are manipulating the microbiome using fecal transplant and other things like engineered microbial consortia to actually hopefully to boost immunity and immunotherapy response in patients with cancer. And then finally, kind of circling back to the antibiotics again, we did two recent studies that highlight the impact of antibiotics in patients with cancer. One was actually published yesterday in Cancer Discovery, which basically showed that when we're using these gut microbiome modulation strategies, we often will give an antibiotic before to wipe out the inherent gut microbiome of that patient and to transplant in an entirely new one. And what we found is that that same antibiotic regimen that's used in infections like C. diff, if we use it in patients with cancer, it actually has bad effects, and doesn't let the gut microbiome reconstitute and respond to immunotherapy. And so there's important lessons to be learned. And that was just published yesterday. We also have some unpublished in manuscript form, but presented in poster form data that suggests that if you give a single dose of Ancef to patients with melanoma who are undergoing surgery, that it can actually disrupt their gut microbiome and their immune system even 3 months after surgery. So really provocative data. So I think, it's a pretty nascent field, but, really important to pay attention. And the time is now to study this and to come together and work together to improve outcomes.
It's really fascinating. It's one thing to show that, the microbiome is an important signal or is associated with things, but it's fascinating to hear how you and others are working on understanding how like manipulating the microbiome either through, antibiotic use or these other therapeutics is very exciting and innovative. Look forward to hearing more about it. As you know, CDC works to provide guidance and resources that help healthcare providers improve appropriate antibiotic use. So could you comment on opportunities you see where we could improve antibiotic use, as well as your thoughts on innovations related to microbiome disruption that can improve other cancer outcomes?
Yeah, definitely. I mean, I was so honored to join this because it's such a unique opportunity, right? And it's great to get people from different fields together to understand this. And I think in short, there's huge opportunities to improve antibiotic use, to improve outcomes to cancer treatment. And, given the increasing appreciation of the microbiome in health and disease and the impact of medications, including antibiotics on the microbiome, the time is now really to address it. One big opportunity, and circle back to what we discussed earlier, antibiotic stewardship, right, in patients with cancer, and particularly in patients undergoing treatment with immunotherapy, either immune checkpoint blockade, which a lot of patients are treated with today, right, and CAR T therapy. Again, this is being used more frequently. And, given the strong data that treatment with at least broad spectrum antibiotics may actually harm response to treatment with immunotherapy, can we actually come together and develop guidelines and really and even pop-ups, on Epic or whatnot that will actually alert us when someone has cancer, is on immunotherapy and comes into the ER with a fever. Do we reach for those broad spectrum antibiotics, or should we have an alert that kind of makes people think twice? But it's, we know that patients with cancer get infections. We heard the data. It's really important that we still treat these patients. But I think in the words of one of my favorite colleagues in infectious disease at MD Anderson, use bullets, not bombs, if you will. And so can we be more thoughtful about our approaches and get more data behind this, right? Because we are now studying different antibiotics. And, there are some antibiotics that we actually have in our stockpile that can actually improve immunotherapy response, and so why not reach for those instead of for those broad spectrum antibiotics? And so I think, we do have an urgent need for guidelines, an opportunity to work together worldwide to develop and implement these. And we can integrate these and incorporate alerts into electronic health and medical platforms, and really make a big difference. And I think long-term, again, policy change, huge opportunity, right? We need to work together to promote better nutrition, potentially rationally designed strategies to modulate gut microbes, with consortia and other strategies. And then policy initiatives will really be critical in these efforts. And I think ultimately, not only is this going to improve really outcomes for cancer treatment, but it's also going to impact cancer prevention. And hopefully we can head off the crisis of cancer developing in younger individuals, which is a real crisis today.
Thanks for mentioning that. I think it's important to highlight that as well. You covered a fair amount. I just had one remaining question, which kind of touches on things that you've already been talking about. But obviously, antibiotic resistance means that drugs that we are using today may not work tomorrow, right? And so our ability to prevent and treat infections in cancer care, may not be the same in the future. So as you think about the microbiome and antibiotic use, is there anything else you think would be important for this audience to hear related to how the impact of antibiotics impacts cancer outcomes?
Yeah, I think, again, opportunities to use novel and innovative strategies to target these microbes, CRISPR-based technology, phage, I think antimicrobial peptides, we have a lot of opportunities to develop next generation strategies that can really target these microbes. There are some microbes in tumors that you can actually selectively target and potentially even prevent cancer altogether. That would be the holy grail, right? So I think, of course, these need resources and they need good minds to come together, and really, I think policy ultimately, but I think, we need some different aspects for research and development. We need to be able to resource these, but I think the time is now to do it.
Thanks. That was excellent and lots of food for thought. And I really appreciate those last kind of comments about other spaces that we need to explore in terms of innovation and product development. I think that there's lots of opportunities for, decreasing the burden of pathogens and treating infections and preventing infections, along with protecting the microbiome. So look forward to hearing more from you and others in this space. And I think we definitely need more to move things forward.
Yeah.
And I think another part of, so go ahead.
I was going to say one last thing. I mean, I think there's, from a global health standpoint, I think there's opportunities. Could we develop some sort of supplement, a prebiotic, probiotic, that could actually promote immunity, improve responses to immunizations, kind of overall health, and I think we could see that in our lifetime.
That's very exciting. And it kind of segues to Minnie a bit. I mean, what I was thinking about as you're talking is that obviously we're interested in treating infections, but we can also use harnessing the microbiome to prevent infections as well. And there's lots of strategies that we're thinking about preventing infections. And so let me turn to Minnie as our last speaker. Minnie, do you mind introducing yourself again?
Absolutely, Sujan. I'm Minnie Kemboj. I'm an infectious disease physician by training. I'm also the hospital epidemiologist at a cancer center. So my research and clinical focus is on infection prevention in patients undergoing cancer treatment and stem cell transplant.
Excellent. Thanks for joining us. So your work involves using novel interventions and diagnostics to address transmission of these different pathogens and preventing hospital-based transmissions of antibiotic resistance pathogens. What are some ways that we can strengthen infection prevention and control efforts in these settings, in settings that are caring for cancer patients? And how can we implement more efforts to combat antibiotic resistance?
Sure, Dr. Reddy. So I want to actually start out by sharing some statistics from the American Cancer Society. So annually, about 1.9 million individuals are diagnosed with cancer in the United States, with 600,000 deaths in a year in cancer patients. And infections actually happen to be the second leading cause of death within the first year after cancer diagnosis. And this is a statistic that has been shared previously by my co-panelists. So before I go to prevention measures, I briefly want to talk about why are cancer patients more prone to infections, and in particular, healthcare-associated infections. So cancer is really a disease of advanced age, although the trends have recently are recently worrisome that we are seeing more cancer in younger individuals. Cancer treatment-associated immunosuppression predisposes to infection. Previous and extensive healthcare-related exposure, extended hospital stays, and antibiotic overuse, these actually happen to be the main predisposing factors for healthcare-associated infections. And lastly, device use, and in particular, I would say central lines. And just to give you an example, in an acute care setting, roughly about 15 to 17% of hospitalized patients have a central line. If you go to an oncology setting, that number is about 55 to 60%. And anytime you have a device, a long-term indwelling device in your body, you're prone to infections. So how many of these infections that happen in cancer patients are due to antimicrobial resistant pathogens? We do not have data on this, as has also been previously recognized by my co-panelists, but we have some information that can be gleaned from CDC's National Healthcare Safety Network, where we do surveillance for infections. And in particular, I will again use the example of central line-associated bloodstream infections. If you look at the top 3 pathogens that cause infection, that cause central line infections, these would be staph, enterococcus, and gram-negatives, E. coli. And if you look at the pattern of resistance among the isolated bugs from cancer patients with central line-associated bloodstream infection, starting with Enterococcus faecium, 70% are vancomycin resistant. Staph, roughly about 45% are methicillin resistant. How about gram-negatives? About a quarter, 25%, have resistance to extended spectrum cephalosporins. So moving on to prevention strategies, and I'll start with MRSA because that's where the largest body of literature is on. Starting with what I would call a very intuitive approach. Let's find out who's colonized with MRSA, institute contact precautions, use gowns, gloves, and see if we can reduce acquisition. Has been studied in a hospital-wide setting, but more widely in an ICU setting with modest reduction in MRSA acquisition. Secondly, how about not go through the labor-intensive and resource-intensive process of screening? Just assume that people have a transmissible pathogen and just follow universal protection, like universal gowns and gloves. Again, has been studied much more in an ICU and other high-risk settings, again, with modest reduction in MRSA acquisition as well as infections. Finally, decolonization, and this is decolonization with chlorhexidine, which is a wonderful skin antiseptic that when applied to the skin can give sustained antimicrobial effects. It's very well tolerated and resistance is not much of a concern. So chlorhexidine universal decolonization has especially been studied in the ICU setting and has shown really wonderful results with reducing MRSA and VRE acquisition. And more importantly, in a recent trial, the benefit extends beyond the ICU. It extends to individuals who have devices. And remember, circling back to people undergoing treatment with cancer, the vast majority of them have central lines. So it was this recent trial that led to really the widespread adoption of decolonization with chlorhexidine with or without nasal mupirocin to reduce device-related infection and acquisition of antimicrobial resistant organisms. Among all these 3 strategies for MRSA, decolonization has been compared head-to-head with targeted intervention of contact precaution, and decolonization really works better and is the preferred approach, and is also more practical and is less resource intensive. Moving on to VRE, which is really particularly a bug of concern in our patients with hematologic malignancies with stem cell transplant. I have to say, sadly, VRE is now hyperendemic or ubiquitous in these settings. So really the seek and isolate approach, or screen and then institute contact precautions, is no longer going to work for VRE. The vast body of literature for VRE control focuses on antimicrobial stewardship. We know that colonization precedes infection, and in particular for VRE, overgrowth is a precursor of infection. And how to prevent that VRE overgrowth from happening is by mindful use of antibiotics in colonized individuals. And this association has particularly been shown with third-generation cephalosporins, with vancomycin, with restricting the use of anti-anaerobic agents. And just like MRSA, for VRE as well, chlorhexidine works really, really well to prevent acquisition as well as device-associated infections. So John, moving on to gram-negative, not so much literature there. What I will highlight is mostly from outbreak control, and that is hand hygiene, environmental disinfection, and antimicrobial stewardship has really been the most effective strategies. One particular point that I want to make about gram-negatives, and more of a research need, is that hospital water systems have recently been found to be a reservoir for multi-drug resistant gram-negatives, and their role has been increasingly elucidated in recent surveillance studies. However, we do not yet know how to do surveillance for them, what an acceptable threshold is, and how to mitigate this risk.
Thanks so much. You covered a lot of ground there, and just one point to mention is just the importance of colonization of these AR bugs, right? That people are colonized with it, and then it helps us decide how to prevent these moving from a colonization status to a infection status. And thinking about the microbiome, as Jen had just talked about, probably is playing a role in terms of how antibiotics play a role there too. And in thinking about other strategies, as you mentioned, like decolonization strategies might be effective. So that was really helpful to hear. As you're talking about the water part and how we may need more innovations in that space, I wonder if you can kind of continue on that thread of what other innovations are needed in infection prevention to really make an impact in AMR and cancer patients.
And for Dr. Reddy, I have a long wish list there, but I'll try to I'll try to keep it brief. So first of all, the studies that I really talked about with decolonization and all the other interventions where the evidence base comes from. It comes from acute care settings mostly, and now long-term care facilities as well. I think what we really need in oncology is we need representation. We need oncology units to be included in these studies. And it's reasonable to extrapolate from existing evidence, but it's better when the evidence comes from the population that it's being applied to. The second most important gap where I feel is, again, has been previously shared, which is we need national benchmarks. We need national benchmarks for the prevalence of antimicrobial resistance and antimicrobial use in oncology settings. A third very important topic that I think there is research emerging on this, but we can do better. We can expand to a point that it can influence national guidelines, is the science of de-escalating antibiotics. There are now studies which have shown that even you're handling a patient with fever and neutropenia, and as long as the patient has Defovest, there is no infection isolated and the patient is clinically stable, you can actually de-escalate. You can step down therapy back to fluoroquinolone prophylaxis rather than broad spectrum antibiotics. And I think we need to expand these studies and really come up with standards that this is safe to do. And finally, I won't take too much time on this, but microbiome restoration, of course, is quite an exciting frontier, as is understanding the role of disinfection for water systems, surveillance, mitigation, and also ventilation systems within the hospital environment.
Thanks, that was great. And my last question to you has to do with your multiple hats that you wear. You're an epidemiologist, and so you have a public health perspective, and you take care of patients as a clinician. So how can we communicate to either clinicians or the public health about these challenges with AMR?
Yeah. So Sujan, given the same infection, a cancer patient is 3 times more likely to die from the same infection as a patient who does not have cancer. And if you take the same organism, if it's a drug-resistant strain, it's been proven again and again that the outcomes are going to be worse compared to a drug-sensitive strain. So this is ingrained in our thinking that antibiotics are this valuable resource for cancer patients who are quite vulnerable to infections. The little downside is that our threshold to use antibiotics in an oncology setting is also much lower. So although we communicate about infection risks and we communicate about the importance of antibiotics, both for prevention as well as treatment, what we don't communicate about enough is that this valuable resource is not limitless and it comes with a lot of downsides, whether it's microbiome disruption, which has been associated with cancer outcomes, whether it's C. diff infection, or whether it's evolution of antimicrobial resistance. And I'll just share an example of a patient I just actually saw in clinic last week. It was a patient who had had bladder cancer surgery. A new bladder had been reconstructed from the intestine. And immediately after surgery, about a year ago, a patient had quite a severe bout of pyelonephritis. And I think it was quite scary for the patient as well as the oncology team. And as a result, over the following year, the patient had multiple urine cultures done without a clinically compatible syndrome and repeated courses of antibiotics given through this. So what actually started out as a severe but a drug-sensitive infection now evolved into a highly drug-resistant colonization. So the point really being that what we need to communicate with our oncology colleagues, with the oncology community, with our patients is the judicious use of antibiotics. Not every fever needs antibiotics, not every urine culture needs to be treated, and not all respiratory illnesses are bacterial.
Thanks, Minnie. And thanks to all of our panelists. I think that concludes our question session here. I wanted to move to one question to everyone. I think we covered a lot of ground here in the last hour or so, from national policy initiatives to improving clinical care one patient at a time, and including like basic science research that needs to get done. My question to the panelists, and we'll start with Shalini here, and then move on to Diane, Jen, and Minnie. Josh alluded to this earlier in the talk, but in September of this year, the United Nations General Assembly will bring together world leaders for the second high-level meeting on antimicrobial resistance. If you could speak to those world leaders, what is the one message you would share about the importance of infection prevention in combating antimicrobial resistance as part of cancer care? Shalini, let's turn to you first.
Okay, thanks, Sujan. So first, I would provide our leaders with a background on why this is so important and why in our work towards ensuring better cancer care for all, the battle just isn't about the disease, the cancer itself, but also against the threat posed by infections and AMR. And by prioritizing infection prevention and control practices and addressing AMR in cancer care, we're not only safeguarding the health and well-being of our cancer patients, but also preserving the efficacy of antimicrobials for future generations. And it's not just about treating cancer, it's about ensuring the cancer care remains effective in an era where antimicrobial resistance threatens to undo decades of medical progress. So I'll first give them this background because not all of them are aware of the interconnectedness between AMR and cancer. And then I would urge our leaders to incorporate robust and sustainable infection prevention and control measures at both the national and facility levels to reduce the spread of drug-resistant infections among cancer patients, and according to what's included in WHO's draft Global Action Plan on IPC, and also ensure access to appropriate quality-assured antimicrobials using the WHO model list of essential medicines. But most importantly, I would urge them to engage with the oncology health workforce and the cancer community in better understanding the magnitude of the problem in order to understand the impact and ensure sustainable solutions with, of course, more importantly, adequate financing.
Thanks, Shalini. Diane, next.
Sure. So I think the focus around not just our cancer patients, but all patients around the globe, what I would want them to really think about is the need to improve the appropriate use of antimicrobials by using current diagnostic tests and implementing stewardship programs around those diagnostics, prioritizing investments in lab infrastructure. So all labs have some capacity to do some testing to support their patients and to inform surveillance. And further expanding that surveillance of AMR at both the local, national, and global levels, so we can have a good understanding of that burden and then establish consensus on meaningful and feasible AMS and IPC metrics. So how do we track the progress? I think all these efforts will allow us to combat AMR as part of cancer care. And I really think in order to do this effectively and be very specific, I think that I would request that the Secretary General, in close collaboration with the quadripartite and other relevant stakeholders, convene an independent panel on evidence for action against AMR by 2025. So we talked a lot on this panel discussion around the need for data. We need data to drive action. So this independent panel could provide independent, robust assessments of the science and data and evidence around AMR to really help us drive forwards in efforts we need to take this year and moving forwards in the future.
Thanks, Diane. Jen, you want to take the question next?
Yeah, sure. I think first I'd thank the members of the UN General Assembly for coming together to address it, and would urge them, of course, to consider the importance of the microbiome in health and disease and the impact of antimicrobials and other factors like diet on the microbiome and on cancer treatment. I think Diane's points are great, and bringing together a panel would be really crucial. I think we do have a unique opportunity to really bring stakeholders together to address this and make a big difference, not only to end cancer, but also to promote overall health.
Thanks, Jen. Minnie?
Yeah, I think my message would be research and innovation to combat antimicrobial resistance must keep pace with the advances in cancer treatment to ensure cancer outcomes continue to improve. I think we've all been in a situation, for example, a patient with acute myeloid leukemia who can receive life-saving therapy but is colonized with a multi-drug resistant organism for which you have no or few therapies. And really, we don't want to withhold life-saving treatment from individuals just because we do not have therapeutic options to manage the complications.
Thanks, Minnie, and thanks for everyone for your thoughts on that. To wrap up today's webinar, I want to hand it over to Josh to see if you have any additional summarizing thoughts for the audience today.
Thank you, Dr. Reddy, and thank you again for the chance to listen and learn and be part of the conversation today. I think the biggest thing I will take away from this session is that we simultaneously need broad policies that get everything from the incentives to the regulations to the research and development frameworks right and in place, not only here, but around the world. But that simultaneously we need action and implementation right down to the individual level, right down to the level of that decision that's being made in the hospital room with the patient and the physician and the families and all the care providers. So figuring out how we simultaneously set the table and set the broad frameworks, but also get right down to that granular choice making so that we can be in a better position moving forward, I think is quite exciting, also quite daunting. Also very much appreciate and recognize the incredibly valuable role of science and technology. These are not issues that we simply declare, we know everything about them and we go home. This is an iterative process. And I like the analogy of S&T being able to keep up with the pace of change around the world and around the country. And then finally, I think certainly a very high level opportunity coming up in New York. And I think that's incredibly important. That said, I also think this is the type of thing that's going to need consistent drumbeat and a consistent level of attention. And so I really appreciate all the stakeholders who joined the call today, recognizing it's not just a 90-minute session, but a life's vocation for many of you, if not all of you. So really appreciate the consistency that you bring day in and day out to addressing these challenges and ultimately to saving lives and making our communities healthier. With that, I think those are my summarizing remarks.
Thanks, Josh. I mean, I think the last point you highlighted is that it's going to take a lot of stakeholders and partners like you all on this call that represent lots of different avenues that we need to pursue. And I hope in the audience as well, that you can take this home and try to think about how we can move this science forward to impact clinical care and improve patients' lives. So with that, I want to thank again our panelists for joining us today. This concludes our webinar for today on the impacts of antimicrobial resistance on cancer care. The CDC will share a recording of this webinar with all registrants in the near future, and we request that the audience complete the post-event survey that will appear. We want to hear from you on future topics for this AMR exchange as well. And with that, we will conclude today's webinar. Thank you and have a wonderful day.